Ideas in STEM Ed is a production of the Idea Engineering Student Center at UC San Diego, which works to promote community, success, and inclusion at all levels. My name is Darren Lipomi, Professor of Nanoengineering and Chemical Engineering and Faculty Director of the Idea Center. The purpose of this podcast is to provide a forum for the discussion of innovative and inclusive approaches to teaching and mentoring, and to support the personal and academic flourishing and success of students in science and engineering. To learn more about the Idea Center, visit jacobschool.ucsd.edu/idea. When I was a grad student, I was really stressed out 50% of the time. At one point, I had a lot of cardiac arrhythmias. After an extensive workup, including an echocardiogram, a cardiac MRI, and a mobile EKG monitor I had to wear for 24 hours a day for 28 days, they told me that I needed to sleep more and try to relax. My primary care doctor, who had been an anxiety researcher's best advice was to, quote, smell the roses. Easier said than done. It's with that backdrop that I'm excited to announce today's guest. I'm speaking today with Dr. Roy Arjoon, cardiologist at the University of Pennsylvania Medical Center. I've known Roy for about 18 years, since he was a sophomore at Boston University in biomedical engineering. I was his undergraduate lab TA in the evening section, which I think was something like 6 to 9 p.m. twice a week. Roy did his medical degree at Boston University as well, his residency at Boston Medical Center.
Let me try to get my wife to take it. Work. I'm sorry. He saw me in the office and ran inside. Say hi to my friend Darren.
No.
No.
I'm sorry. Let me have my wife take him, and then I'll be right back.
All right.
But Daddy's doing work, okay?
I want to do work.
Good work for Mom.
Roy did his medical degree at Boston University as well, his residency at Boston Medical Center, a research fellowship at MIT, and a cardiology fellowship at Yale New Haven Hospital. Roy, thank you very much for coming on the program.
Thanks for having me, Darren. Yeah, I probably would have made it through the medical school part without you.
Well, I'm not sure that's true, but I'll take any part of your success that I can. So what led to your interest in medicine?
So I actually spent most of my life trying to avoid going into medicine. So like most Indian parents, my parents wanted me to do medicine or engineering or law. And I wanted to be a Ghostbuster. That obviously didn't work out because I found out later I was afraid of ghosts. So when I wound up going to college, I applied for biomedical engineering because I thought it was kind of a cool area that was starting out. I was always pretty good at math, and I thought it was a nice way to not just do straight math. And from there, when I finished biomedical engineering, I didn't really know where I was going to go next. I didn't really want to work in an office. I knew I had to go do some kind of grad school. And the people part of medicine appealed to me a lot. So that kind of drove me towards medicine, because I kind of needed to do something and I didn't like everything else. And I really like people.
Is that unusual? Most engineers are not necessarily people who, they like people, but you know what I'm saying?
Yeah, I think the prototypical engineer is kind of like, is into their work and doesn't really like to socialize. I don't think that's how most of my friends were when I was in college. I was friends with a lot of outgoing engineers. And I think it's ultimately how you want to decide how the rest of your life is going to be. Like I meet new people every single day, and I hear their life story, and I think all of that is fascinating. I don't think I could have been in an office seeing the same 20 people every single day for the rest of my life. I don't think that would work for me. But there's a lot of people that may work out just fine for.
What is a cardiologist?
So a cardiologist is effectively a heart doctor. We do 3 years of internal medicine training. So it's like kind of general medicine. and then 3 years of medical cardiology fellowship. So I think a common mistake is people think we do surgeries. We don't cut up anybody's chest or anything like that. That's cardiothoracic surgery. There's subspecialties within cardiology. So I do imaging stuff, specifically echocardiography and nuclear cardiology. But there are other cardiologists who will do interventional. Those are the cardiologists that will put in stents and people have heart attacks. There are cardiologists that manage abnormal heart rhythms, kind of similar to what you may have had. And there's cardiologists who manage heart failure. Those are the three big kind of subgroups of cardiologists, but none of us will cut up anybody's chest. Some of us are more procedural than others, but everything would be effectively like minimally invasive through the leg or neck or something like that.
Mm-hmm. Just like I think that some people think that a neurologist is the same thing as a brain surgeon.
Yeah. Yeah. I think some people get disappointed too. They're like, oh, do you do heart surgery? It's like, no, I take pictures though of the heart.
But it doesn't disappoint you because you're not down for the wet aspects of medicine, if I remember correctly.
There are parts of the wet aspect that I don't like. Like pulmonologists, lung doctors, they do stuff coming out of your lungs are not pleasant. Gastroenterology or GI tract doctors, stuff coming up and down, not my cup of tea. Blood was never really something I cared that much about, so it kind of fits nicely with what I decided to do, because there is sometimes a lot of blood.
So as somebody with training in biomedical engineer, what do you know or appreciate about the function of the cardiovascular system that the median cardiologist might not?
I think at this point, I'm probably as good as most other good cardiologists, but I think
You mean the other ones are as good as you?
As good as me, yeah. I mean, there are a lot, particularly at Penn. Everybody here is just geniuses. So I think compared to all of them, I don't think any of them know any less than I do, even though they don't have an engineering background, most of them. I think the big difference is coming into cardiology fellowship. I think it made a huge difference. I think having an engineering background sort of hinders you going into medical school, because it's just like at least when I did it, I never really memorized a lot of stuff going through college. A lot of it was kind of learning the concepts of stuff and figuring your way through. I think that's how a lot of engineering is. And then when you get to medical school and test questions are literally like, what's the fifth word on the 872nd page? It kind of threw me for a loop. So the first exam I had was pretty rough. And then I kind of realized this is a different ball game than what I was used to.
Did you have a taste of that, like studying for the MCAT?
I did. I mean, I think standardized testing is one thing. I never really had big issues with standardized testing. I think the amount, so when I started medical school, what they told me on the very first day was it was going to be like, you're going to be given information through a fire hose. And everybody thought it was really funny then, but it is 100% true. You just have to learn so much so fast. And I don't think I was quite prepared for that from engineering. And a lot of the beginning of medical school is a lot of basic science stuff. So I think the beginning part, unless you do a lot more basic science than I think we did in our engineering curriculum. I mean, I did orgo and bio and all of that, but that was like basic pre-med stuff. I think it sort of hurt me at the beginning. But once I kind of adjusted to things, it was fine. And then once I got into internal medicine, I think that's where kind of the cardiology thing really started to pique my interest, because I found that, everything in cardiology is either electricity, flow, or solid mechanics, right? It's literally those three things dictate everything in my world. And I had all that stuff for 4 years, and I had spent 4 years getting pretty good at it. So when I got to medicine and they would like quiz me on all this stuff, I was like, oh, this makes 100% intuitive sense why this is the answer to something. So that's what kind of led me to cardiology. And once I got into cardiology, when you get into the nitty gritty of things, whether it's heart failure or electrophysiology or interventional, it's really those three things that still are the fundamental principles that guide it all. So it was very easy for me to understand all those concepts and apply it to patients on a day-to-day basis. So I think what I lost going into medical school, I gained like 1,000-fold when I started medicine and going into cardiology.
How much of medical school have you retained?
I think a lot of the basic science stuff I haven't. But you'd be surprised. Like I've particularly because I went into internal medicine. So general medicine, you go through a lot of the stuff you learn in medical school. It's a little bit different if you go into a surgical specialty or like ENT or ophthalmology or anesthesia. I think it's a little bit different. But general medicine is everything you do in medical school. That's what medical school is. So I did that for 3 years, and I did cardiology. So I would say 75%, 25% I think is useless now, but 75% is still, I think, fairly. I think it's applicable too if you want to be a good overall doctor. Like I still pride myself on being able to do non-cardiology stuff. Like I take care of patients in the ICU who nowadays are more complicated than just they had a heart attack or they have heart failure. You know, they could have any organ could be messed up in the ICU. So I'm still proud of the fact that I can still take care of all those patients and sort of know what I'm doing. But I know the basis for all of that is from medical school and general medicine.
What did you learn about yourself studying and retaining information? What is a good strategy when you're drinking from a fire hose of information? Is it a matter of seeing it again 3 years later when your career depends on it, or is there another way to think about it?
I mean, and as far as like how I studied, that kind of
how you studied, how you think you're able to retain it. I mean, it's surprising to me. I mean, how much 75% of the information when you drink it from a fire hose, and it's coming fast and furious, and many years later, you know,
right,
you still have it.
I think a ton of it is repetition, because a lot of the stuff you see over and over on different tests or in different books or in, you know, even now you'll see it in different patients and you just go like refresh it real quick and it all comes back. I mean, when I was studying, I was always pretty good at if I read something once or twice, as long as there was something on the test, like multiple choice tests, I would do well because it would all come back once I saw the words. So I was never, I never really did note cards and all of that stuff. I would just read the stuff like 5 times and like highlight and underline and say it over my head like 100 times. And eventually it would just stick. But I think from medical school till now, the stuff that you see over and over, particularly the stuff that you remember like getting wrong in the past, just stays with you after you get it wrong too. So like I still remember test questions that I got wrong that I know the answer to now.
To what extent does curiosity aid in retrieval and recall?
I mean, I think if you're not interested in a topic and curious about learning more about it, then I think it becomes a miserable experience. Because I know there are parts of medicine that aren't interesting to me at all. And because I don't have that like curiosity to know more about it, those are actually the areas that I have to like read about again to know what's really going on. the stuff that I still maintain an interest in, I remember all of it. It's like I've told you, hematology, oncology, I think was very rote memorization. And because of that, I just never could get interest in it. And because of that, I don't know a whole lot of hematology and oncology.
That's what interests me about people who know a lot of stuff. I was listening to an interview with Ken Jennings, the original like Jeopardy long running champion who won, I don't know, however many games in a row. And people asked, like, you must have a wonderful memory. And he said, no, I'm just curious about a lot of things. And then it makes the memorization a lot easier. And you don't even really view it as memorization. So it's interesting to hear you say that. Of course, an engineering education, as you mentioned, is quite different in terms of, maybe concepts and problem solving versus like facts and problem solving. Right. Although there's a lot of overlap too. Yeah. I would imagine. That's one aspect I find interesting about somebody who achieves some level and how they're able to connect it to what they've learned in the past. Okay, how about this? How much of organic chemistry do you still remember?
I could say not much. I could tell you I knew there was a benzene ring, but I remembered so little that I was embarrassed to ask you if that was a benzene ring behind you.
Oh, on my whiteboard the last time we talked. Yeah, I erased that because I'm sure there was a Texas carbon in it. No, just kidding. I have a PhD in organic chemistry. I know what the structure of benzene is.
There's not a lot of there's like in pharmacology, there's probably when I was going through pharmacology in medical school, there's probably a decent amount of orgo related to it. But at this point, not really.
So if you prescribe somebody like a beta blocker or something, then you kind of know what it does.
I mean, I will say that. So some of the stuff that comes up for me is like statins and beta blockers have different like rates of adverse reactions depending on their hydrophobicity. So if they're lipophilic, one thing will happen. If they're hydrophilic, something else will happen. So that's probably as far as it goes for me. But the rest of it is kind of like physiology kind of stuff. What a beta does, what a angiotensin receptor blocker does, that kind of stuff.
Got it. When you were studying, was there ever a time when you wanted to give up? And if so, how did you get past it?
There was never a time where I wanted to give up because I think I had worked so hard to get to that point. And like my family was all excited that I was in medical school. And
how about a super frustrating time?
Yeah. I mean, like I tell you, that first test. So my very first medical school test, I went into it like I went into a lot of prior tests. I was like, I'll be fine. And I like watched the Yankees Red Sox until 3 a.m. and then tried to cram 2 hours, 3 hours for a test, fell asleep. Then I woke up, I was like, I do fine on every test I've ever taken. And then I failed my first medical school test. So that was a very eye-opening experience. And I had to go meet with like the dean of the education, all that. And I was like, is everything okay at home? Is it too hard? Just like, no, everything is fine. I'll be fine. And I think that was where I kind of realized what I got myself into. And, it was going to be more work than I think I initially anticipated. I mean, there have been times, going through training. I mean, medical school is medical school. You have a ton of people with you. It's basically like you're just learning still. When you get to residency and fellowship, other people's care are in your hands. So, something bad happens to a patient or you work I would have like 30 plus hour shifts in a row or, be a consult and you think the consults are stupid. Like those are frustrating days. You'll come home and you're like, I don't know why I bothered with this. But those feelings usually last for like a day, because like realistically, you're not going to back out at that point. And then the next day comes on and it's better. I think every doctor has the days where you have a frustrating patient, something bad happens to a patient who you like, or any patient, or you have like a frustrating interaction with a colleague. All those things happen. And for that time period, it's really frustrating. I know my wife's a cardiologist too, and I remember times she would come home and just throw her pager against the wall. But we all got through it, because the next day usually you forget what happened the first day. I mean, medicine has a good way of, it's like pounding you into the ground one day, and then the next day you make like a cool diagnosis, or you meet somebody really nice, or some family thanks you for taking care of their mom.
Mm-hmm.
So I think that's typically the cycle in medicine, regardless of what specialty you're in. Because I have a lot of friends in other specialties, and everybody says the same thing. Everybody has their moments, and then most of those moments are fairly fleeting.
Yeah, I can understand that. As even as an educator, I think someday you get like a grant rejected, or maybe you have to deal with a difficult student or a terrible like course evaluation, but then the next day you get like an email from a student that tells you what your course meant to them. And I think it doesn't come as fast and as furious, I think, as it does in medicine, but I can half empathize with what you're saying.
And I have because I'm essentially like an academic attending too. So I do some teaching, and you get the same pros and cons of that. I mean, there are some people you work with who are fantastic, and there are others less so. So I feel all the pluses and minuses as well.
So how many trainees or supervisees do you have at any one point?
So there are multiple fellows in the program. At any given time, maybe one or two will be rotating through the hospital. I'm pretty lucky to be at Penn. The Penn fellows are phenomenal. So I've had an awesome experience here with teaching.
And these are doctors who have already been through residency.
So they're doctors who are in cardiology fellowship now. And we'll usually rotate together through whether it's like the ICU or on the floor. And, they get a lot of teaching from me. I sometimes get a lot of teaching from them. So it's a nice back and forth. So it's been awesome. I very much enjoy that aspect of things. You don't really get that in private practice. So I think there's some distinguishing stuff there, depending on which way you grow a career.
Do you find that you take, is mentoring to you something that you do naturally, like charismatically, or are there specific mentoring tools or mentoring approaches that you use that are more effective than others?
I've always been kind of a conversational person with that kind of stuff. When I do teaching in the hospital, it'll kind of be as days go. I think almost every patient has something you could learn from them, whether it's like dealing with a personality, dealing with a new diagnosis, that kind of stuff. So it's easy as we go along. I try not to keep things particularly serious. Like I used to do PowerPoint stuff, and I've kind of gone away from that more recently. I'll still draw stuff on paper and stuff like that, but I found that the PowerPoint thing would often get too formal and nobody talks, and it was just me rambling on and on. So now I just like, what do you guys want to talk about today? And just like make up some patient scenarios, that kind of stuff. But yeah, I usually don't come prepared with something. Sometimes they'll want to talk about some esoteric thing, and I'll have to go read about it. to pretend like I knew what it was beforehand.
So they'll email you and they'll say like, I want to talk about this esoteric thing, and you're like,
Yeah,
and
exactly.
then,
It's like, yeah, no problem. And then I sit in my office for 2 hours reading about it.
Tell me about your research experience at MIT. This was after your residency, right? You did
Yes, I did a year of research with Elazar Edelman over at MIT, who is fantastic. We were doing some flow stuff with stents and how you have perturbations in flow depending on if the stent is up against the wall of the vessel or not. And then I was trying to do some modeling of coronaries with some of the 3D software. I learned a ton during that year. A lot of it was kind of fluid dynamic stuff that I think was helpful going forward into clinical practice. So when stuff goes wrong with a stent, a lot of times I could like understand why it happens. It doesn't happen often, but he was also an awesome mentor and just like getting through into fellowship and what to expect going on. And there was a guy I'd worked with who was a postdoc in Brazil who was a cardiologist. It was also like when you're not in it, right? I wasn't a cardiologist yet, or even when I was in residency. Like when you hear war stories from people who are at where you want to be, that also gets you like really excited. So they were telling me all these stories about stuff they did to take care of patients. Like, oh, that's so cool. I want to do that. That was also just like an exciting thing to know this is going to be my future.
Did you have to do it between residency and fellowship? Did you have to do research?
You don't have to do research between. My wife and I were a year apart, so I needed to find something to do for a gap year.
Mm-hmm.
And all the research I had done was engineering related. That's the kind of stuff I like to do. So he was doing stuff that was both kind of engineering / clinical in nature. So it kind of fit everything I wanted to do. I don't do any research now, but it was a good time.
Do you ever work with companies like instrument makers, device makers, or consult with engineers in any capacity?
I don't. I mean, I'll meet sometimes. So I do. There are these structural cardiology cases now where we'll like fix valves or put stuff in the heart through the leg. And I do the imaging for that. So sometimes when we're doing that kind of stuff, engineers from the company will come out, particularly at the beginning of the process of starting the procedure at the hospital. So I'll meet them there and chit chat about the device and how they came up with it and that kind of stuff. But as far as giving my input into anything, no. There's some people, there are probably a lot of people tend to do that, but I am not one of them.
Mm-hmm.
I thought about it. I think it becomes like a time thing. You have X amount of hours in the day, and at most places you're not going to get like this is your consulting time. You got to carve that out on your own. So it was just too complicated. Like I do my clinical job and then come home and hang out with my kids.
Yeah, of course. I totally understand. I'm looking for ways where we can connect your engineering background to our engineering student audience.
Sorry.
It's no problem. I only have a few more minutes. Anyway.
Sorry.
So are there any particular cardiovascular diseases that I don't know if excited is the right word, but like when one comes in, you're like, I got this. Like I'm excited to treat this. Or like, do you have any like what are your superpowers in terms of
So I'm obviously biased, but I think all of cardiology is just incredibly cool and interesting. And, I think the difference in cardiology compared to some other specialties is people will come in kind of high acuity. So they'll be super, super sick. And if you play the right cards, they get better pretty quickly, or they don't. So cardiogenic shock is, to this day, it's like a 50% mortality rate.
Describe that? What's the
cardiogenic shock is basically because of your heart, you're not perfusing blood to the rest of your organs. So effectively the blood coming out of your heart isn't enough to perfuse. And those patients come in like on fire, sick a lot of times. And if you think through the physiology, and a lot of it is engineering based, right? So it's basically your cardiac output is dependent on your systemic vascular resistance. And if you're able to, basically drop your SVR, your resistance, your cardiac output will go up, and everything gets better. So how you go about that, there are a lot of different ways. That's effectively what you're doing. And when it works, it's like magic. So like you get these numbers and you're like, I know what I have to do. I just have to lower the resistance here, flow will go up, and I win.
How do you do that? Like, how do you change the resistance? And
so there are medications that'll lower the resistance that the heart's facing to get blood out, and then kind of decongest. So as the blood stops, as the heart stops squeezing well, the pressures get really high in the heart, and then that backs up fluid into the lungs. So a combination of dropping your resistance beyond the heart and decongesting all that fluid via diuretics like Lasix. So both those things will lower the pressures in the chambers of the heart, and that'll also get things to get moving, get their blood pressure up, and everything starts getting better. It's really like a pressure problem, a resistance thing, and it all just like works out beautifully when it works. They're the sickest cardiology patients, and they're probably like the most engineering physiology of all of them. Like heart attack, a lot of heart attack patients, they have a blockage. You open the blockage, and they get better. Some of those people will go into cardiogenic shock. Electrical patients, you kind of deal with the electrical problem, but the cardiogenic shock people, I think, are the most interesting and most rewarding when you're able to get them out of the fire.
Is a blockage usually the cause of that? And what's the difference between cardiogenic? Yeah,
it's probably the most common blockage. The most common cause of cardiogenic shock is probably post-heart attack. But people could have it. They could have a low squeeze related to a prior heart attack, and whatever reason they go into it. And the other cool thing about it is in the last, maybe 15, 20 years, people have started developing a lot of devices to try to help with that. And anytime there's a cardiology device, it's usually pretty cool. So there's intra-aortic balloon pump, which is kind of old now, but it'll go in your aorta and will blow up the balloon when your heart is in diastole, and then basically shove blood up your aorta into your coronary arteries, and then it'll pull the balloon down when your heart's in systole, and then suck blood out of the heart. And then there's an Impella device now where they'll go in through the aorta, and it has this little Archimedes screw at the end. It'll just like spin up and pull blood out and spit it into your aorta if your heart can't do it on its own. And now there's ventricular assist devices where they basically put in a pump into the heart, and it'll pull blood out of the bottom of the heart and stick it into the top of the heart, kind of into the aorta. So, all these devices they're all like, they're engineering marvels.
Yeah, no kidding.
So I think that's also one of the really cool things about being in cardiology. I don't think most of the other Probably in some of the surgical subspecialties, there's a lot of stuff. But in cardiology, I think it's a big, the whole cardiogenic shock thing is a big area for companies to try to put resources to and develop new cool stuff.
How is it different from congestive heart failure?
So it's sort of this, they're similar. So people with congestive heart failure, if it gets bad enough, can wind up in cardiogenic shock. So congestive heart failure effectively means that the pressures in your heart are too high. So fluid is going sort of backwards into your lungs. And then you get that better by, well, most of the time, giving people diuretic, and you pee out salt, and that'll lower the pressures in the chambers of your heart. The people who have a low squeeze causing congestive heart failure, they're the ones that tend to benefit from lowering their resistance, and because their heart's kind of poopy to begin with. So if you have a not so great heart squeezing against the high resistance, everything goes downhill. So you kind of try to reduce the amount of work on the heart by lowering their resistance, and people have a low squeeze. People who don't have a low squeeze, that doesn't really apply, but.
Yeah, one last technical question. So as somebody like me who's interested in the mechanical properties of materials, as well as stress and psychogenic diseases, in what ways does stress and anxiety manifest clinically to a cardiologist, and how do you work with a patient whose cardiovascular issues are like psychological origin?
So it's kind of interesting. There's a thing called a stress cardiomyopathy, and it's called broken heart syndrome. So the classic thing is somebody will have a very stressful event, and people don't really know how it works. I think one of the more accepted ways is that the sympathetic innervation to the heart just kind of spazzes out, and then part of the heart won't squeeze well. And you put those patients on medication for congestive heart failure, and it tends to get better within 2 weeks or so. But it's very interesting, because the entire inciting thing can be somebody got into an argument, somebody's family member died. I had somebody watching the Republican National Convention, and that caused it. So I think in its purest form, you can have that. And there are people who I don't know how much like true pathology happens with like anxiety, depression, that kind of stuff, but people could feel symptoms. I have a lot of patients who get palpitations and feel like their heart's fluttering. When we do all this stuff with the heart monitor, whether we find something, I think that's more often than not, we don't, but they still have these symptoms. So yeah. However those symptoms are happening, I don't know, but it's clearly something mentally related, because there's nothing happening as far as the heart's electrical system goes in those people, but they sure feel like their heart's skipping.
Right.
I don't have an answer for that one.
Yeah. Got it. All right. So as a professor, we sometimes check out our course review scores, right? Like our ratings. And I had this question. So originally, your wife, Ashley Brogan, who's also a cardiologist at Penn, was going to be on here, but she had to take care of childcare duties because she'll be at home right now.
And we'll switch roles.
We'll switch roles. She'll be back. So I was going to mention that on the Penn Medicine website, Ashley has a 4.9 rating out of 5, and you only have a 4.7 out of 5, which is a fantastic rating. But I'm wondering if you have an explanation for that. What are those 0.2 all about?
I think my wife is an overall fantastic cardiologist. I think she does a much better job, I think, than I do about chit-chatting about stuff that isn't particularly relevant to people's hearts than I do. Like there was one time she was like telling me about somebody who had playing some basketball game. I was looking for a game to play. I was like, Ashley, why are you talking about where they play basketball? It's like, oh, I just found it interesting. Like, oh. And I think people like that a lot. And it also helps that she is like cardiology savant. She's one of those people who can quote papers and tell you everything about every topic in cardiology. So I've ridden her coattails to this.
But you have told me though that your bedside manner is calming to some type of people who come in totally freaked out about their condition, and you just tell them like, statistically, this is nothing. Don't worry about it.
Yeah, I mean, I don't think it's helpful for somebody who's a cardiologist at a quaternary care hospital. We see the sickest of the sick. And if I were that patient, I wouldn't want somebody coming in panicking about what to do. I don't think that gives much of an aura of confidence. Whether people like when I joke around when they're in cardiogenic shock, to keep the mood light when they're sick, that's debatable. Some people like it, some people don't. I can't please every patient that walks in the door. I see, when I'm in clinic, I probably see 20 patients a day. And in the hospital, it could be like 20 something patients a day. Not every one of those are going to be happy with every decision I make. But I think at the end of the day, I know that I'm taking as good care of them as any great cardiologist would. Not that I'm saying I'm great as I came out of my mouth. I'm confident what I can do, right? I think I'm a very good cardiologist. And I think people's personality in medicine are all different. My wife is also a fantastic cardiologist, but she enjoys hearing about every aspect of somebody's life in a 30-minute office visit. I try to focus on the cardiology stuff because in that short amount of time, it's debatable how pertinent somebody's basketball game is.
Well, I would want either one of you as my cardiologist if I found myself in.
Us is any patient one of us sees basically has two cardiologists.
It's a real bargain. Well, since I have a history of long cardiac workups, next time I'm in Pennsylvania and experience some kind of crisis, I will tell the EMT where to take me.
Appreciate it.
All right. Thank you, Roy, for doing this. Good luck with everything. And likewise. Take care.
Take care, man.
Thanks for listening to Ideas in STEM Ed, a production of the Idea Engineering Student Center in the Jacobs School of Engineering at UC San Diego. This episode was edited and engineered by Sky Lee, with theme music written and performed by John Viviani. Title art was created by Caitlin Wong. Special thanks to Sarah Eckert for guest booking and marketing. The Idea Center works to promote community, success, and inclusion at all levels. To reach us for guest suggestions and other feedback, please send an email to ideadirector@eng.ucsd.edu. And to learn more about our programs, visit jacobschool.ucsd.edu/idea. As a final note, the views expressed by me or the guests do not necessarily reflect those of the Idea Center, the Jacobs School of Engineering, or UC San Diego. See you next time.